Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for 12/29/2022, the last conference of 2022. Today, we've got a great case. Dr. Gash, she's going to discuss. We've got some fun polls, and hopefully, we'll generate some good discussion. Today's CME activity code is 487203. This will be recorded and uploaded by Dr. Baxi on our YouTube channel. Anybody is not subscribed to that, please do. And if you're not on our email list, let us know and we'll add you. You can direct message us, we'll add you to our email list. Everyone is muted except the faculty. Put all your questions in the chat box and we'll try to address them as we can. As usual, we have nothing to disclose, and our privacy statement is as follows: to ensure patient privacy is preserved, and identifying information and or other details have been changed to disguise the identity of the patient and to protect patient confidentiality. And with that, I'm going to hand it over to Dr. Gashti, who will present his case for us. Casey?
Yes. Our patient is an 80-year-old gentleman who has Alzheimer's, dementia, spinal stenosis. He's had laminectomy surgery a few years back, BPH. He's had his prostate resected, transurethral resection of the prostate. He has hyperlipidemia, rheumatoid arthritis for about 15 to 20 years. And he has some degree of unknown CKD. He's basically here in the United States to visit his son, who lives here in Chicago, but he's from the Middle East. So he comes to nephrology with swelling of both of his feet since he's been visiting here for the past 2 months. His son reported that his father had some edema when he arrived. That's 2 months ago, but it's been significantly worse over the past week. He has a photo of a lab on his phone from back in his country that shows us his creatinine was 1.5. This is around 6 months prior to our encounter, but he doesn't have any other records, no urinalyses or anything else. The patient has been suffering from acute worsening of hearing loss and has been seeing ENT. He was on 2 different courses of antibiotics, most recently Augmentin. He's also been self-medicating with diclofenac, which is an NSAID for his back pain, which he's had chronically. Upon presentation, his serum creatinine was elevated to 3.6 from that 1.5 6 months prior, and his protein in your proteinuria was 12.5 grams per gram with a serum albumin of 2. So the diclofenac was discontinued. He had already completed Augmentin without any improvement in his hearing loss. His review system was positive for memory loss, hearing difficulty, bilateral lower extremity swelling, anorexia, fatigue, and depressed mood. Past medical history is, as I mentioned before, social history. He was a prior smoker. He smoked for probably 3 to 4 decades, quit about 20 years ago. He has an alcoholic drink occasionally, on and off, maybe 1 or 2 a month. No illicit drugs, no family history of kidney disease. He's currently on olanzapine every night, rosuvastatin, donepezil, which is Aricept, as well as memantine. These are all for his dementia. He has no allergies. His exam, his blood pressure is 102/60. The rest of his vitals are unremarkable. He weighs about 50 kilos and with a BMI of 20. He appears pale. He's hard of hearing, has a flat affect. His cardiovascular exam is unremarkable. His abdomen is soft and non-tender, but he's pretty anasarchic. He has edema all the way up to the sacrum. He has a laminectomy scar on his back. He does have some arthritic changes in his hands with his MCP and PIP joints having moderate arthritic changes, and he does not have a skin rash. His labs show a sodium of 133, potassium of 4.4, chloride of 106, bicarb of 18, BUN and creatinine are 50 and 3.6 respectively. His glucose was 120. His albumin is 2 with a total protein of 6.4. He has a normal adjusted calcium and normal LFTs. His white count is 9.3 with a differential that's listed, hemoglobin of 11 with an MCV of 87 and platelet count of 350. His total cholesterol is 233 with an HDL of 37 and an LDL of 167. His ANCA was negative. His rheumatoid factor is less than 15. His SID rate is 80. His anti-PLA2R was negative, and his viral serologies, including Hep B, Hep C, HIV and COVID were all negative, and Quant Gold was also negative. His urinalysis, light yellow clear with a specific gravity of 1017, pH of 6.5, lots of protein, 1+ blood, 2 WBCs, 3 to 5 RBCs, 2 granular casts, and 2 hyaline casts. His urine protein was 1037 milligrams per deciliter. His urine albumin was greater than 500. It wasn't really specifically quantified, and his urine protein to creatinine ratio was 13.6 grams with an albumin creatinine ratio of at least 6.6 grams per gram. His serum protein electrophoresis had no monoclonal peak with a kappa of 12.5, lambda of 4.5, and a kappa lambda ratio of 2.75. His urine protein electrophoresis had total protein of 475 milligrams. Of that, 70% of that was albumin, and again, no paraproteins. He had a CT abdomen pelvis, which shows symmetric kidneys. On CT, they did not comment on the size, but he had a 1.8 centimeter simple cyst in the midpole with no hydroureter or hydronephrosis. So a percutaneous renal biopsy was performed.
Thank you. We have 2 polls, but before we get to that, any questions for Dr. Gashti?
Do you have a colonoscopy? I mean, do you have like up to date with his age screening colonoscopy and all that stuff?
So he did. He has been. He had a colonoscopy about maybe 5 or 6 years ago, and at the time they found a small polyp. They said repeat in 5 years, so he's due for one. But I don't have records of any of this.
The hearing loss was conductive or neural?
So it was conductive. He eventually ended up having ENT, essentially put a tube across his tympanic membrane, and his hearing actually has improved. The antibiotics didn't really do anything.
Okay.
All right, we're going to do this a little different today. We're going to start with a couple polls. Praveer, if you can pull up the first poll. So, would you, in addition to considering anticoagulation, we're not going to discuss that part today, would you, in addition to considering anticoagulation, number 1, stop nonsteroidals for 4 weeks, then biopsy if not resolving? Number 2, stop nonsteroidals, start steroids, and if not resolving in 4 weeks, biopsy? Number 3, stop nonsteroidals, steroids, and biopsy now? Or number 4, stop nonsteroidals and biopsy now? Your voting is anonymous. We don't call anybody out, so we'd like to get a well-represented poll here on what people think. Still coming in.
It's pretty good.
Yeah.
Got a few more seconds here. All right. You can see the results.
Okay, is the results up?
Yep.
Okay, so we have one person for option number 1, stop nonsteroidals for 4 weeks, then biopsy. Few people say stop nonsteroidals, start steroids. Actually, the second favorite choice. Stop nonsteroidals, start steroids, and if not resolving, in 4 weeks, biopsy. 3 at 15%, stop nonsteroidals, start steroids, and biopsy now. And 4, just go ahead and biopsy. Stop nonsteroidals and biopsy now, which is our number 1, but only hardly a mandate at 60%. So I threw this out as a kind of an interesting question, and I want to ask Dr. Gashti, what did you do, Casey?
I did number 2. I stopped the NSAIDs. I started steroids, and part of that was because the guy just really looked frail, and he had just gotten here from overseas, and just doing all of this stuff was just very overwhelming for him. So I said, let's just start steroids, and if he doesn't get better, we'll biopsy you.
Interesting. Okay, so let's do poll number 2 now. You'll get some follow-up later, but I just wanted to let you know that he actually opted for the least popular choice there. I think he gives it a reasonable argument. We can talk about that later, how reasonable it is. What do you think this patient has? Minimal change or another podocytopathy, kind of in the focal sclerosis range. That's really what number 1 is meant at. Number 2, minimal change disease with interstitial nephritis. Number 3, membranous glomerulonephritis would be PLA2R negative membranous glomerulonephritis. And number 4 would be a rheumatoid arthritis related lesion.
Roger,
Yeah.
as soon as you finish this poll, I have a couple of questions.
Okie dokie.
Good responses so far. All right. Come on, last few. I know you're out there, Dan Andrioli. Make sure you vote.
All right. What we have is 8% say MCD or podocytopathy alone. The highest one here is MCD with interstitial nephritis. I suppose getting along the lines of the non-steroidal exposure. Number 3 is membranous with 3 people, and the last one is an RA-related lesion, which is 6 people. Dick, what are your comments
Well,
or questions? I'm sorry.
in light of the fact that this patient at age 80 has a blood pressure systolic of 105, and we don't know what country he comes from, I wonder about amyloid. Now, I don't think he has rheumatoid arthritis because his rheumatoid factor is negative, and even though burnt out rheumatoid can certainly have deformities, would be rather unusual to have a perfectly normal rheumatoid factor. And I'm wondering whether this patient has, if he's from Turkey, I would include, a differential diagnosis of some kind of autoinflammatory disease manifesting with joint disease. And I would have considered doing a subcutaneous stat pad biopsy before doing a kidney biopsy. That's
So you're
just a
referring
comment.
to familial Mediterranean fever or things that go beyond that?
What?
Are you talking about familial Mediterranean fever or that as well as, or beyond just that?
Well, I mean, the blood pressure of 105 systolic in an elderly person would not be considered normal. That's pretty low. I would have done a Valsalva to be sure that his sympathetic nervous system was intact. I don't know what his orthostatic blood pressure and pulse are. I'm just raising the issue of an elderly patient presenting with nephrotic syndrome from a foreign country.
Dick, is that something you'd think it'd show up at 80?
Well, it's a little old, but he may have had proteinuria for a long time. We don't know.
All right. Good points. Interesting. So where I want to go now is I think it's time to discuss the case. I'd like to ask Dr. Corbett to tell us what his thoughts are about this patient, what he thinks this patient has. Steve?
Sure. I think the NSAID associated minimal change with interstitial nephritis is definitely entertaining. And that first poll is always, I find this always very perplexing because it's always hard to know what the right answer is for that. They all could be right, really. It's just a matter of what your preference is. But I like that. I mean, he's got a normal blood pressure or on low normal. He's edematous. We always talk about the cholesterol. His cholesterol is high, but it's not as high as we always talk about with minimal change disease, which I think in this case would be a red herring. But I like that minimal change associated with NSAIDs, which, the interstitial nephritis would be one of the things that would be helpful in making that distinction. If it's a lymphocytic for the most part, even though they can have some eosinophils, usually it's more lymphocytic and plasmacytic as opposed to things like Bactrim or, sulfa or penicillin associated interstitial nephritis. Podocytopathy is always a possibility with acute renal failure, just from, maybe he's got a lot of vascular disease with a low albumin like this. He could have some ATN. But I think membranous is also a good possibility in this gentleman. It would fit. I mean, all these findings would be consistent with a membranous lesion as well. It's hard for me to make this FSGS It's hard for me to make it an MPGN or anything else. Amyloid's always an interesting thought, and as Dick was talking about FMF, I mean, that's a possibility, but as you allude to at 80 for the presentation, unless it's just missed, which it could have been, that'd kind of be a little unusual. There was an issue about the kappa lambda ratio. It's 2.7. Normally it's up to about 1.65, but in somebody with this level of renal function, up to 3.1 is considered normal. So I think that's kind of a red herring. The SED rate being elevated, I think, is nothing more than a reflection of how significant the proteinuria was. I remember there was an ASN abstract years ago that basically suggested for every gram increase in proteinuria, the SED rate went up by 15. So I think that SED rate just goes along with the nephrotic syndrome. I don't have a long differential. I think and in a way you kind of baited everybody with all the NSAID questions right from the get-go. So I kind of gone down that rabbit hole because I think it makes a nice, it would be a nice case. I have this funny feeling that it's a setup, which is why I probably should say it's membranous, but I think the minimal change from Casey, the Voltaren, which he was on the generic, when was that discontinued relative to the biopsy?
So about 2 months.
Yeah, because
8 weeks.
In our experience, which is a limited one, but it was Roger's co-fellow, Greg Warren, we looked at our small experience and 80% of those patients after 2 weeks were in remission. I think one of them, it went out to like 4 weeks, and there was there were both acute renal failure with nephrotic syndrome, and some of them actually just had nephrotic syndrome alone. So if he was off of it 2 months, even though I guess it's still possible, that kind of makes minimal change a little lower down on my list, and I think I'm going to put membranous higher up now. And a PLA2R negative membranous. But yeah, so maybe this
he's a pretty thin guy. Then
you got to worry about
5'3". Yeah, he's 5'3", and he's very, very skinny. He's skin and bones.
At his age, you got to worry about something lurking, and I think membranous might go higher on the list now. And an occult malignancy I'll throw out there as a big possibility needs to be ruled out, especially with this NSAID having been stopped for 2 months. And I'll stop there.
Steve, when I was a fellow, one of the early things I learned about the differential diagnosis of nephrotic syndrome is age. And I think it was probably you that said, anybody that's 80 that has nephrotic syndrome, you should think about two things.
Amyloid and malignancy, I guess.
A minimal change.
Or minimal.
Because it's bimodal and it picks up again, So, I mean, that's kind of, they're definitely in the differential. You don't like focal sclerosis because why? The blood pressure or?
Yeah, he doesn't have any hematuria. The blood pressure's good. And I guess, again, I've gone down the rabbit hole of the NSAID associated. You're right. It could be idiopathic. It could be primary minimal change as well.
I mean, I look at this. He only has 2 to 4 or something, 3 to 5 white cells. It's not real impressive for at least interstitial nephritis associated with non-steroidals. And although he does have some renal failure, and so it's really hard to say. And that was even before we realized how long he's been off the.
So you're going to debate my differential, or you're going to have your own?
I think I like your differential. I think it's an excellent differential. I just trying to see where you're coming from. That's all. Let me ask you this, Steve. I mean, and I don't know the answer to this, but if somebody's already on a statin, wouldn't that attenuate their cholesterol? Because I look at that cholesterol and it's up there, but it's not that impressive for minimal change disease. You think it might be a lot higher, and maybe that's hiding. If I'd have given you a cholesterol 350.
I mean, usually, good point. I mean, usually though, with these people that are on statin that get nephrotic, their cholesterol is still skyrocket. It's not like the statins control it, and so I guess what would be interesting if we had it is if we knew his total cholesterol was 100, and then all of a sudden went to 200. I mean, then or 230. Then you could say, yeah, that might be a result of the statin keeping it low. But if he's been 200 all along. These patients that are severely nephrotic, even on a statin doesn't always control it. Now, granted, this isn't, it's greater than 200. It's still just slightly above normal. His LDL is high. I mean, it's high, but it's not as high as I would have expected. But you're right. It could definitely be a factor. I'm not aware of any of these Alzheimer's medications as being associated with a renal problem per se. I guess that's another thing to bring up. But Casey, I don't know if you are, Roger, but I'm not aware of Aricept or any of them having any kind of renal manifestations.
Casey, no, I'm not. Casey, his RA, Dick brought up the point of, Dr. Gillespie brought up the point of the rheumatoid factor being negative, but he definitely had high hand changes, very consistent with this. I'm assuming that's what you're saying in the physical. Was he treated for this, his RA?
So he used to be on infusions back in his home country, and he hasn't been obviously here because he was just visiting. And he in fact had stopped, I think, about 6 months prior to coming here for insurance reasons or whatever, price reasons. So that I do have to say that the rheumatoid factor, Dr. Glassick pointed out that it's really low. Just the way this case evolved, that number is drawn when he was already on steroids for a while. So I would advise caution on interpreting that as being low, that he doesn't have RA because he was already immunosuppressed when the rheumatoid factor was drawn.
But the issue with if you're going down the rabbit hole of RA and secondary amyloid, those people are usually very active for a very long period of time before they develop amyloid and proteinuria. I mean, and generally my understanding is, that they'll have proteinuria for you'll see it's not like a sudden onset of nephrotic syndrome, if you will.
Yeah, I think that's a good point.
Well, familial Mediterranean fever can present late with amyloid without any external manifestations. And polyarthritis is one of the manifestations. So the reason I bring up amyloid is not necessarily rheumatoid arthritis related amyloid. I don't think that's really tenable. It's late onset idiopathic nephrotic syndrome and low blood pressure that makes me worried about amyloid.
No, that's a good point. And it's one of those things, if you don't think about it, obviously it's never in your differential, and it's a good point.
So Dr. Glassick's top choice is afebrile familial Mediterranean fever. I like that.
Ooh.
And I'm just coining a new term, but yeah, like I've seen 0 cases of MMF, so I have nothing to say about that except what I can possibly read. I think it's time for the wheel. I'd like to point out that this is the last spin for our second year fellows, and come the new year, it will switch over to the first year fellows. If they don't quit the fellowship in the next week, because they now know they're going to go on the wheel. So I've got my stuff ready to go. Hopefully the wheel will work today on a first spin. Good. Great, Kelly.
All right, give me a second here.
Dr. Schlotman is a second year fellow and chief fellow extraordinaire. Kelly.
Okay, so we have 2 cores here. This is the trichrome stain. So looking for chronicity here and any evidence of scarring. So I do see quite a bit of blue staining material. The tubules are definitely not all back to back. Looking at this core at the top, the tubules are definitely spaced out quite a bit. I assume this.
Yeah, it's going to be subtle, but that area where you are there, yeah, there's no
Here?
glomeruli. No, just to the
Yeah.
right of that. Yeah,
Oh,
it's the
yeah, here.
transition from the cortex to the medulla. So yeah, that's
Okay.
not all fibrosis in there. Yeah.
So this would be medulla, is what you're saying down here?
Yeah, on the far right, it is medulla. I think that's actually part of the arcuate artery.
Oh, okay.
Tangentially cut.
Okay, so then down here, this core down here, maybe this, I don't know if that's a glomerulus here, but here. Okay, so here's one glomerulus here. Okay. And then the tubules here are a little bit more back to back, I guess. Definitely still some scarring. Maybe like, I don't know, 50% or so scarring. I'm not sure.
Yeah, and it looks less than that to me.
Okay,
Yeah. Yeah,
Okay.
I estimate about 25% or so.
25%. Okay. All right. Okay, so we have two glomeruli here. This is the H&E stain. Starting with the glomerulus over here. This looks like a normal glomerulus. Capillaries appear open. Capillary loops appear open, got Bowman's space, and then Bowman's capsule. Don't really see any scarring around the glomerulus either. Glomerulus on the left here, we have some more kind of mesangial stuff. I don't know what, like mesangial expansion, I guess. There are some capillary loops that I do see open. I think this is the hilum here.
Yeah, so the expansion, does it look symmetrical throughout or kind of asymmetrical and amorphous?
It looks amorphous.
Yeah.
Yeah.
Yep. Yeah, it looks like there's a big kind of blob of it right there down at
Right
6
here.
o'clock. Yep.
Yeah. Okay, and then the tubules, I don't see a lot of like interstitial infiltrate. I know interstitial nephritis was one of the things on the differential, but I don't see any evidence of that here right now. Anything else on this slide, Dr. Simbulik?
No, that was good.
What are you thinking, Kelly, on in terms of that material, or what's our things on our differential?
Yeah, so amyloid was definitely one of the big things on our differential. And then, so this is definitely concerning for amyloid at this point. Okay, so moving on to the PAS stain, focus on the glomerulus right here in the center. So here again, we have like the amorphous material and kind of in the middle of the glomerulus, weekly PAS staining, which is consistent with amyloid, standing for amyloid. Otherwise, we have the tubules that look back to back. So here we have like are these the protein reabsorption?
Yes. Yep.
Okay, droplets. And then we did have granular casts in the UA, so I would assume that we'd see some ATN, but
What's next to the one that you were just looking at with the reabsorption droplets?
this?
No, keep going the other way. Go one more, right there.
Oh, is that a cast?
Yeah,
Or-
Highland cast.
Yeah, just a Highland cast. Okay.
Yeah,
It
it
looks
looks
a
like
little
there's some
fractured
ATM
though,
there
no?
though. The epithelium's thinned
Oh.
out and there's no brush border.
Sorry, where, Dr. Simbulik?
Oh, in the cat in the one with the Highland cast.
Okay.
Looks like it's acutely injured. The epithelium's thinned out and there's no brush border on the tubule.
Got it. Okay.
Oh, in terms of David, do you feel like that's more nodular in terms, or no?
No, I don't see any
Mostly
nodule.
mesangium. Okay.
Yeah.
And so, is it, Kelly? Do you think it's what in terms of differential? What does anything point towards one of the differentials people had?
Well, we were talking about essentially like a AA amyloid from like longstanding inflammatory rheumatoid arthritis. And then we were also talking about amyloid from FMF.
And so would there be anything on the PAS stain that you'd look for?
Are you talking about like the weekly PAS positive?
Mhm.
Yeah. So it is definitely weekly, like lighter pink than you, I feel like I always compare it to the Bowman's capsule. That's like a darker, always stains a little bit darker pink. All right, so moving on to the Jones stain. Looking at the basement or the capillary loops, I don't see any breaks. Membranous was another thing that was on the differential. So looking for any spikes or holes that would indicate any evidence of membranous. I do not see any very obvious spikes or holes. I'm not the best at that though, unless it's super obvious. But I don't see any evidence of that. in this glomerulus.
Very good. Mario, do you see any of these eyelashes that are described with amyloid?
The what?
We say coxcomb,
Eyelash sign.
over in our
Mark
neck of the
Simpson
woods.
sign.
Yeah, right there.
Yeah, I see a couple others, but it's, you know, I'm looking really hard and I want to find it, but I see a couple areas, you know, a little bit to the right of that, looks like there might be some kind of it looks like spikes, but they're a little different. They look more
Yeah,
like
if you,
feathery
where it was,
eyelashes
if
or
you keep
coxcomb.
going straight to the right.
Right
yeah,
there.
right.
Oh, you
Oh, you
almost
were
had it.
on them. Okay.
Go to the right.
To the right.
Right. Oh, a little more.
Yeah. Keep going.
Go.
Oh.
Right there.
Yeah, right there. Yeah, there you go.
Oh, I see. Okay.
So
I
what
think
you
it's
guys
a really,
call
really
this in
cool
the
finding.
foreign
And,
country of
you know,
Chicago?
it's not a diagnostic finding, but it's always fun to find. And
Oh,
Dave,
What
do
do
you
you
agree
guys
those
call
are
it?
abnormal and that could be?
So David, what is the name that you guys use for the eyelashes finding?
A coxcomb.
Coxcomb, that funny thing on a rooster's top of their head. But they call it an eyelash sometimes. It's very feathery. Somebody did a nice tweet. They called it a Bart Simpson because it looks like the top of Bart Simpson's head.
All right. Here's the Congo red stain, which is positive. We see the amyloid staining positive here in this glomerulus in the center. And I assume this is going to be polarized light and it's going to be positive.
Yep, apple green birefringence.
Kappa and lambda are negative on immunofluorescence. And then here we have EM, randomly kind of organized fibrils that are around 10 nanometers.
Yep.
Can't you stain for amyloid A protein or no?
Given that he is from a foreign country and that's a send out stain, it was almost as fast just to send it for mass spectroscopy. So that's
We'll
what
talk
we did.
about that.
I
But,
would say these,
obviously-
I would say these are randomly distributed, not organized.
Yeah, they kind of use
Organized
that term.
deposits, they'll have sheaths or it'll be in fibrillar aggregates. This is the typical random orientation of non-branching 10 nanometer fibrils, classic for amyloid,
And without periodicity.
without periodicity. Right.
Or a tubular structure.
Here it is. What does that mean, Dr.
Now,
Corbett?
if you go high enough, these are microtubules.
Yeah.
Oh,
The way they're formed, they are, but they're just so small, you really have to magnify them to see it.
Yeah.
oh,
Yeah,
okay.
thanks, Steve. So what is your pathologic diagnosis?
Amyloidosis. Yeah.
No.
Yeah, would you say, I mean, I don't think you could say it's not AL
Not AL.
because of the immunofluorescence, and I think that's all we're left
Yeah.
with right now. Great. Steve, what do you think about this?
Well, if it's familial Mediterranean fever, I mean, the patient's got amyloid. The question is what's causing it. We know it's not light chains. If it's familial Mediterranean fever, then you can treat it with colchicine, right? If it's
Does that help
secondary-
my impression is that does a lot. Oh, actually, I don't know. I'm speaking without knowing, and I'm going to ask if people know, but I know it's useful for the serositis and some of the extrarenal symptoms. I don't know. Does it change? Does it impact the renal disease at all? Anybody know?
I mean, I would have to look it up, but that's what I thought the treatment was. But I can't answer it any better than that right now. Without going back, I mean, I don't even know if I've ever seen a case of FMF, to be honest with you, other than to read about it for the boards. If this is, secondary amyloid from something else, then this whole, the whole issue of gag mimetics, which we've talked about numerous times, hasn't really been all that beneficial in the long term, and it seems to have kind of been dropped out of favor. I mean, the real issues for these secondary amyloids is treat the underlying condition. So I guess ultimately we have to decide what's causing this.
Well, it's your patient. What do you
Well, Roger,
Yeah, Dick.
just to address that, colchicine is primarily a preventative therapy for amyloid. Once you've developed nephrotic syndrome from AA amyloid due to familial Mediterranean fever, colchicine is ineffective. So at this point, if he's asymptomatic from the standpoint of polyarthritis, skin rash, other inflammatory, I don't think colchicine is going to do anything. And at this level of serum creatinine, he could also get toxicity. So I wouldn't think that amyloid, that his diagnosis, which I think is presumptively AA amyloid, based on his country of origin and his clinical presentation and the biopsy, we don't have anything to treat him with.
Yeah, I mean, if it's not rheumatoid arthritis related, if not inflammatory bowel disease, those things, osteomyelitis, again, you treat the underlying issue. The gagmometics, like I said, I don't even know if they're available still. I remember the New England Journal article that must have come out now 10 years ago or more. I'm not seeing much about it because it really didn't pan out to be very beneficial, because I don't think preventing the fibrils from forming is really the issue. I think it's the ground substance, whatever that protein is, that's creating the amyloid, that ultimately is the thing you need to stop producing. So I don't know what else to do for this gentleman, to be honest with you, other than symptomatically treat him. Or conservative therapy, if you will.
So Casey, I'm going to hand it back to you. Before you talk a little bit more, tell us exactly why you biopsied him, and a little more about your thoughts, and then I asked Dr. Gash to kind of give us a little bit of deep dive into the diagnosis of amyloid beyond Congo red, what we have now with immunohistochemical stains and mass spec, etc. So back to you, Case.
So when he presented to me, he was hospitalized. He was pretty frail, and so we talked about biopsying him, and the son, who was sort of his main power of attorney, was like, can we just kind of treat him and see what happens? And I had a pretty high suspicion that there was something going on with regards to the NSAIDs. So I put him on steroids. I put him on prednisone 60, and then he didn't really tolerate 60. So he was basically on 40 milligrams of prednisone for a total of 8 weeks. His creatinine did come down from 3.6 or 3.8 down to his 1.5 baseline. So his creatinine improved to his baseline from 6 months ago, but his proteinuria stayed at 10, 12 grams, which now we know why. So at that time, I figured there was probably something else going on. So we ended up doing a biopsy, which is what we saw. So I assume if we had done this biopsy 8 weeks prior, we would have seen some interstitial nephritis from the NSAIDs, or some reason why his creatinine was so much higher. So there was some benefit from the steroids, but clearly the underlying reason for the proteinuria was the amyloid. It may have gotten worse by using NSAIDs, but it didn't seem like it got better after discontinuation in 2 months of steroids. So this is kind of where we are. And so we sent the tissue to Mayo Clinic. Can I have control, Prevere? Thank you. And he basically did have serum amyloid A by mass spec. So he does have AA amyloidosis. So we kind of have to, as Dr. Glassick mentioned, figure out what that underlying cause is, whether it's rheumatoid arthritis or FMF or something else. Dr. Rodby asked me to kind of talk a little bit about the Congo red and the mass spec, and sort of how we ended up treating this patient and diagnosing the patient. Congo red has kind of an interesting history, both politically and from a patenting standpoint. It actually was a textile dye that was invented in Germany in the 1880s. The guy that actually invented this ended up competing with what ended up being the Bayer aspirin company. They weren't interested in this dye, so they ended up going to a competing company, and there was a legal battle about whether that's a patentable thing. And so the court in Germany decided that it was unique enough that they granted patent, and that sort of set the precedent for what would qualify to be patented and what was sort of like a common and easily reproducible dye. So that was one interesting thing. And the name itself, Congo, was during the times where European countries were sort of dividing Africa into different pieces for colonization. And Congo was sort of carved out as this tax-free haven for people to sort of do exchanges in. And so the name Congo Red sort of comes from that, that sort of conference of Europeans in Africa, and they named the dye after Congo Red. It initially was used as an IV. They used to infuse Congo Red intravenously, and then they would check plasma level. If the plasma level was low, the assumption was that the dye was bound to amyloid fibrils in the body, and that would make the diagnosis of amyloid. Eventually, they started actually staining tissue with it, which was a lot more pleasing because these patients didn't have to have Congo Red infused into them, followed by immediate blood draw. It's interesting because all amyloid does react with Congo Red, and no matter what the precursor protein is, because of the way these amyloid fibrils are formed, and because they have these fibrils that sort of form these helices within the fibril, the Congo Red has this orientation where, obviously under polarized light, we see this 90-degree angling in the beta pleated sheet and the way the Congo Red actually binds to them. So in the process of diagnosis of amyloidosis, the first step is to actually diagnose it. The second step, which is also really important, is to actually type the amyloidogenic protein, precursor protein. It probably didn't matter 20 years ago because we didn't have specific treatments for different kinds of amyloid. But nowadays, we do have specific treatments. You know, if it's AL amyloidosis, we tend to send them to hematology for clone-directed therapy. If they have a transthyretin, which is usually a cardiac type of amyloid, there are now, you know, approved drugs. Tafamidis, which is Vindamax, is now approved for treatment of transthyretin cardiomyopathy. There are drugs, for example, you know, FDA approved drugs for Alzheimer's. You know, there's some interesting sort of interactions here because this guy does have Alzheimer's, but the beta amyloid in the brain that's been implicated in amyloid, there is now monoclonal antibodies that were approved in 2021 by the FDA, the aducanumab or something like that, that was approved, although it was controversial because the results were not that great. But regardless, we have some treatments that are emerging. So now typing of amyloid has become much more important. So if you look at the renal amyloidosis types, most of them, and this number kind of varies depending on what series you look at, but most renal amyloidosis and even extrarenal amyloidosis tend to be AL. And if it's not AL and non-AL amyloidoses, then you have to subtype them into whether they're sort of inflammatory amyloids or infectious amyloids, or if they're genetic types of amyloids. We also have ALEC2, so we do have these other types of, you know, leukocyte chemotactin factor 2 sort of subproteins that can lead to non-AL amyloidosis. So it's important to kind of distinguish what the protein is. And so how do we do that? How do we actually identify these proteins? There are two main methodologies. One is antibody-based, which is essentially utilizing either immunohistochemistry or immunofluorescent or immunogold. And these are very routinely done in a lot of the laboratories. So this is widely available. It requires some technical expertise, but you don't have to go to Mayo Clinic, for example, to get it done. The problem is that you have to know what you're looking for. So you could look for AA, AL, transthyretin, and some of the other ones. But if it's some of these more rare and exotic amyloids that, you know, we're not looking for, it could miss that. So that's one thing. The other thing is that it has a limited sensitivity and specificity because of the non-specific interaction between the fibrils and the antibodies. So although this is a very good first step, mass spectroscopy seems to be better in the sense that it can identify essentially non-discriminately all these known and sometimes unknown amyloidogenic proteins. It is quite complicated because it follows several steps. It's available at, you know, very large referral centers, and it uses tissue microdissection, and so you have to have formalin fixed paraffin blocks to send to, for example, Mayo Clinic to get it done. And that's essentially what we did. So how does mass spec actually work? Let me see. All right. So there are a few steps. So when you send the tissue to Mayo, the first thing they do is they actually stain it with Congo red. So they identify, first of all, they confirm that the tissue does have amyloid fibrils in it. And then they use a laser microdissection. So they cut out that section that has a good amount of the fibrils. And they go through a variety of steps. One step is to, for example, extract that protein, and they use trypsin to digest all of the peptides out. And then they use a high-performance liquid chromatography, and they actually separate the peptides into different groups based on their weight. And one of the steps that's important is they actually add charge to the protein. That's called ESI, which is electrospray ionization. This is something that was developed in 2002. Actually, the two people who invented this actually won the Nobel Prize in chemistry for doing so. It's essentially adding enough charge to a protein that you could put it into a mass spec and move it, but it doesn't actually destroy the protein. So there's a really fine balance there. So once you do that, then you put it inside the mass spec, and it kind of flies from one side to the end plate. And based on how fast they fly, because that depends on their size and their molecular weight, then they could be separated out. This actually happens in two different steps, because initially they measure the parent mass spec, and then the molecules are actually broken down because they collide with each other. So there's this collision-induced dissociation, CID. So they measure it again. So there is two layers of mass spec measurement. So they measure the parent peptide, and then they also measure the fragments of that peptide. And the machine will then spit out this graph, which will say, okay, we found these proteins. So now you have to take this map and you have to compare it to a database that was priorly created. It's almost like thinking of using a fingerprint to identify a person. You have to have a database of all the fingerprints, and then you say, okay, this is this guy's fingerprint, this is what he has. And so this would be an example of somebody who would have, for example, an IgG lambda constant chain and an IgG lambda variable chain that was found in mass spec. And you also have these other proteins like apolipoprotein E and serum amyloid P components. These are present in all kinds of amyloid. These are amyloid signature proteins. So no matter what kind of amyloid you have, you're going to find these in mass spec. But what's different is that you will find these other proteins that are essentially parts of the original pre-amyloidogenic protein. So these green boxes here essentially show you the abundance of that protein. They usually run 3 to 4 samples at a time, and then they essentially add them up and say, okay, this patient has an IgG lambda monoclonal protein, so this would be like an AL amyloidosis. So Mayo actually did publish a comprehensive review of about 16,000 cases that they had, which was kind of interesting because they have found 27 plus proteins that are associated with 21 different types of amyloid. So these are really comprehensive databases that we can use. And as you can see, both apolipoprotein E, which is the top row, which is all green, and serum amyloid P component, those are positive in any kind of amyloid that you see. So that's not really a discriminatory finding, but what is different is then what else do you find? And in the AL amyloidosis, in AL lambda and AL kappa, you would find lambda chain, both variable and constant regions, and you will also find the constant and variable regions of the lambda. And so this is a really neat methodology to separate out the protein and then compare it to the database. So this is essentially proteomics. And even more interesting, they could actually tell you, based on their 16,000 plus cases, what's the propensity for developing amyloid within different organs. So within the kidneys, for example, AL amyloidosis is the most common, but the second most common, at least based on the Mayo experience, is the LEC2 amyloidosis, followed by AA amyloidosis, and so on and so forth. So AA amyloidosis, which is what this patient has, is not very common in the heart. So this can actually help you try to go look for other organs that, may be involved. So, for example, if you're, most organs are affected by AL. So if you look at the blue boxes, every organ has AL amyloidosis, but in non-AL amyloidosis, if you have ALEC2 in the kidney, the likelihood, 21% in the liver. So you'll look in the liver, in the spleen, in the lungs. So this is really very sort of interesting in a sense that, you can kind of organ specific types of amyloid. So this is sort of the Mayo experience, and this was all possible based on their mass spec analysis of the data. So what happened to our patient was he initially presented with a creatinine of 3.8, put him on steroids, his creatinine went down, and then steroids stopped. He wasn't really responding from a proteinuria standpoint, got biopsied, sent mass spec to Mayo, got AA amyloidosis. Now the question that's raised is, FMF versus rheumatoid arthritis. So he does have rheumatoid arthritis. He does have some arthritic changes in his hands that are compatible with that. He was using NSAIDs for pain control when he was off infusion, so he was having some arthritic pains. He was symptomatic. The rheumatoid factor, as I mentioned, was drawn somewhere in the middle of this curve where the steroids were high in dose, maybe 20 or 40. So I think maybe that was a little misleading. And so, yeah, anti-CCP was positive. So at this point, I think he does have rheumatoid arthritis associated secondary AA amyloidosis. And so I sent him to rheumatology because he's now coming off of steroids and his joint pains were starting to flare up again. So he's now on Enbrel. Interestingly, there are about 7 or 8 cases of Enbrel in patients with rheumatoid arthritis and AA amyloid in the kidney that have shown stabilization of the creatinine and reduction in proteinuria. And I was trying to figure, so one of the the mechanism of how these fibrils actually cause damage is not entirely understood, but it's not all about the old fibrils that are deposited in the tissue, because they think that the profibrils are actually more toxic to tissue. So if you could stop inflammation and stop formation of those profibrils before they even deposit, that can improve clinically, that can improve outcomes. So anti-inflammatory drugs in this particular case are going to be helpful. He doesn't have any history of periodic fevers, abdominal pain. He hasn't had this since childhood. So there are a lot of things that make me think this is not FMF, and it is rheumatoid arthritis induced, but that's kind of where we are right now. His creatinine is 1.5. He's doing pretty well. He's gotten 2 or 3 infusions of Enbrel. His proteinuria is still 10 grams. I don't think that's going to get better. That's what I have.
His creatinine's hanging tight at 1.5.
It's 1.5, yeah.
Yeah. Well, I think that's a reasonable approach since we don't have a treatment for familial Mediterranean fever anyway. And, treat what you can treat. I'm sure the question's going to remain there. I just grabbed my Natera genetic 382 genes, and this was printed a couple of years ago, and they can do a genetic test for familial Mediterranean fever. Personally, I would love to see that done because I think it would be very curious to find out. I'll bet Dr. Glassick is still in the FMF category here. Dick, what do you think? You think this is familial Mediterranean fever, or you think it's RA?
Well, I think the anti-citrulline antibody test probably locks it in as rheumatoid. I would still like to do a genetic study. We have this peculiar late onset, which is seen in Mediterranean fever. I want to correct the statement. I said colchicine is not effective in AA amyloid with late onset, but tocilizumab and anakinra have been used successfully in amyloidosis due to FMF. Now, this guy probably does have rheumatoid arthritis, but I must say the absence of rheumatoid factor and the clinical inactivity of the disease makes me wonder what's going on in this patient. And I probably would do a genetic study.
Well, I think since it's available, I think it's a great idea, and I think it would be a lot of fun to find out. And certainly, regardless of what he has, the thought about this as a differential for his amyloid is really excellent because it's not something we see here in America. You know, it probably is very high on the list in certain countries, but it's not something we really think about here. And he's not from.
Roger, what is striking to me is this improvement in his serum creatinine with steroids. Amyloidosis, including AA, is not a steroid-responsive disease. He doesn't have interstitial nephritis. Why did his serum creatinine fall so quickly after steroids?
Maybe it was dissolving.
Dr. Glassick, I think he probably had interstitial nephritis. The biopsy was 2 months after the steroid. So I think that the creatinine came down because of the steroid effect on interstitial nephritis. This biopsy that we saw was 2 months after steroids.
So you're taking Hickham's dictum. He had non-steroidal anti-inflammatory interstitial nephritis superimposed on AA amyloidosis, and the steroids improved his GFR but didn't improve his amyloid.
I have no other explanation.
Well, what about creatinine production? Myopathy, I mean, steroids destroy muscles. A guy is already very lean, and I wonder, I mean, I would have done a serum cystatin C, which would have been a much better indicator of what's happening to his GFR. I don't think creatinine eGFR is a very useful tool in a patient like this. And that's the only thing I want to point out.
If this were, if his GFR were the same and his creatinine went down from muscle wasting, his creatinine almost went in half. This means his muscle mass would have had to go on in half in 8 weeks.
Right.
That's a bit of a stretch, but it's still a good point.
Yes, it is.
Mario, I don't know. Could you actually tell us what the Mayo found on their mass spec?
Yeah, they found serum amyloid A.
Okay, that was off the tissue this patient's tissue.
That was mass spec. Yes.
Okay, yeah, I'm sorry, he put it in there. Yeah, so, but they're not able to tell you anything more than that. It's just amyloid A, and we're kind of left with the broad differential of amyloid A.
It's chronic inflammation or infection. That still doesn't it doesn't tell you what's causing the inflammation. It just tells you that's what is serum amyloid A. That's all it says.
Mm-hmm.
Now, let me ask you a question. I was under the understanding that the amyloid of FMF is genetically linked. So isn't Mayo able to tell you whether this is FMF related or not?
No.
Somebody said no. I agree. No, they were not able to. They basically, when I can actually pull up the report. Pravir, I sent a picture of it, but I feel like they basically said this is serum amyloid A. They were not able to distinguish that from FMF AA.
So this is more in keeping with a positive CCP without A.
Yes.
The amyloid, Mario, the amyloid in FMF is serum amyloid A. The same protein that's found in rheumatoid-associated secondary amyloid. There's no biochemical difference between them.
Okay.
So I think Casey is right. The Mayo Clinic group can't tell you whether this is AA secondary to MMF or secondary to rheumatoid arthritis or osteomyelitis or tuberculosis or whatever.
Thank you.
Yeah, it's funny because we're talking about the high sophistication of all this and how far we've gone, and here we're still left with the highest level, and we still don't know exactly where it's coming from. So I like the genetic testing. I don't know if you'll be able to talk him into it, Casey, but we'd love to hear about that, maybe in some follow-up some point. Any other comment? Here we go. Here's what came back from Mayo Clinic. Just basically saying similar amyloid A, which is what was been pointed out. No matter what the inflammatory condition is, we can't get any more specific than that because it is that protein. Well, thank you, everyone. Thanks everybody for their comments. Dick and Mario and everybody else. Casey, what a great discussion. I love history. You know how much I love it. That was really interesting. And the Congo Red and the whole thing. And I honestly, That's quite a, I asked for a moderate dive and you did a deep dive. I give you a lot of credit to be able to understand it that well. Really appreciate that. Thanks, everybody. This is our last for 2022. We'll see you all next year. And until then, stay safe.
Roger and all the guys at Rush, I want to, as a participant, I want to thank you all for a full year of great learning and great teaching. I'm looking forward to 2023 with great anticipation.
Dick, we're so tickled that you come every week and enthusiastically and usually nail the case.
Yeah.
But be that as it may, we're so thrilled that you could join us, and Mario and everybody else. It's what really makes this conference special, and we appreciate your comments.